donde vengo, aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy que han marginado. Soy con orgullo embajador de mi país. Tiene de donde vengo, aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera leñando tiri. Soy paraguayo. Que han marginado. Soy con orgullo embajador de mi país. Tiene de donde vengo aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente. Y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera leñando ti. Soy paraguayo. Soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera leñando tiri. Soy paraguayo. Que han marginado. Soy con orgullo embajador de mi país. de donde vengo, aires campestres. Tiene el sudor en mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy que han marginado. Soy con orgullo embajador de mi país. Tiene de donde vengo, aires campestres. Tiene el sudor en mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo. Que han marginado. Soy con orgullo embajador de mi país. Tiene de donde vengo aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente. Y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo. Soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. vengo aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa. Soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca. Soy del trueno entre las hojas. Soy de Augusto al escribir. Tiene mi Paraguay también su historia. Tiene a los goles de José Luis. Tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy que han marginado. Soy con orgullo embajador de mi país. Tiene de donde vengo aires campestres. Tiene el sudor de mi tierra en su sufrir. Tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes. Tiene a mujeres dignas de parir. Tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo. Soy las canciones de un maneco enamorado. Soy artesano y mi bandera el ñandutí. Soy paraguayo, soy liberal, soy febrerista y colorado. Soy de la tribu guaraní que han marginado. Soy con orgullo embajador de mi país. Soy de la capital de la galopa, soy sangre paraguaya y de raíz. Soy bendición que va de boca en boca, soy del trueno entre las hojas, soy de Augusto al escribir. Tiene mi Paraguay también su historia, tiene a los goles de José Luis, tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo, soy las canciones de un maneco enamorado, soy artesano y mi bandera leñando tiri. Soy paraguayo, soy liberal, soy febrerista y colorado, soy de la tribu guaraní que han marginado, soy con orgullo embajador de mi país. Tiene de donde vengo aires campestres, tiene el sudor de mi tierra en su sufrir, tiene la calidez que hay en su gente y una danza se hace fuerte en la guitarra de Agustín. Tiene también mi pueblo a sus valientes, tiene a mujeres dignas de parir, tiene literatura inteligente, tiene un toque diferente, tiene idioma guaraní. Soy paraguayo, soy de la tierra del jazmín y del trabajo, soy las canciones de un maneco enamorado, soy artesano y mi bandera leñando ti. Soy paraguayo, soy liberal, soy febrerista y colorado, soy de la tribu guaraní que han marginado, soy con orgullo embajador de mi país. Soy de la capital de la galopa, soy sangre paraguaya y de raíz, soy bendición que va de boca en boca, soy del trueno entre las hojas, soy de Augusto al escribir. Tiene mi Paraguay también su historia, tiene a los goles de José Luis, tiene a Manuel Ortiz, tiene a sus obras, tiene encantos, tiene gloria, tiene empuje juvenil. Soy paraguayo, soy de la tierra del jazmín y del trabajo, soy las canciones de un maneco enamorado, soy artesano y mi bandera leñando tiri. Soy paraguayo, soy liberal, soy febrerista y colorado, soy de la tribu guaraní que han marginado, soy con orgullo embajador de mi país. tiene de dónde
de
vengo.
5.000 citaciones en todo el mundo sobre el tromboembolismo venoso, la insuficiencia venosa y temas relacionados. Ha dado conferencias, más de 5.000 conferencias en todo el mundo sobre una variedad de temas, fundamentalmente tromboembolismo venoso y cirugía. Ha desarrollado últimamente una aplicación que es muy importante, que les quiero recordar para los jóvenes residentes que andan permanentemente con su celular en la mano. Esta aplicación muestra el score de Caprini y el score de Caprini modificado, que lo está procurando de cambiar para los pacientes con COVID, que es muy importante para tenerlo para todos los pacientes. Ha sido presidente del American Venous Forum, de la Sociedad de Cirugía Vascular, que es la sociedad más prestigiosa de los Estados Unidos, así como el American Venous Forum. Miembro honorario del European Venous Forum, del American College of Surgery, y actualmente trabaja fundamentalmente en dar esta nueva actualización para que realmente llegue a nosotros la información sobre estos pacientes que estamos tratando. Professor Caprini, you're more than welcome. Thank you very much. With deeply in my heart, I'm more than happy to share all our excellent people who are working here in Paraguay, trying to learn from you and your expertise to see how we can fix that big trouble with the COVID issue and thrombosis. Can we start your video? You will be shared your screen, or you want to that Manuel release the video? What do you think will be better?
No, I can share the screen. Do we want to start now?
Yeah, sure. Let's go ahead.
Before I start this video, I'd like to again extend my sincerest appreciation for all of you and your confidence in me in trying to go ahead and present these data. And I hope they will be useful for you. And we have to remember that we're in a new era. And we can't go back and say, well, there is no evidence or we don't have trials. We are in an area where we have to try to take care of these patients the best way we can. And we're going to improvise a lot. And then eventually we will come to the conclusions, but it's going to be trial and error. And of course, that's why they call it the practice of medicine. So now I'd like to go ahead and start this presentation.
Associated with the disease. The daunting challenge of saving patients who develop severe acute respiratory syndrome coronavirus is just one clinical challenge, but the necessity for urgent elective surgery introduces a whole new level of complexity. Here are my disclosures. So, coronavirus and thrombosis, what do we know so far? We realize that the virus-induced inflammation triggers a cytokine storm, causing tissue factor release, thrombin generation, and fibrin formation. And this fibrin is designed to coat the virus and prevent its spread and replication. Now that's a great mechanism, but it has one unfortunate side effect: thrombosis. The activation of thrombin induces a hypercoagulability that can be measured with a D-dimer and fibrin split products. Deep vein thrombosis, pulmonary embolism, stroke, arterial thrombosis, all may occur. But we have to remember that microvascular thrombosis is occurring all over the body and may result in organ insufficiency or failure in the lungs, liver, kidney, or even brain. The fibrinolysis is a reaction to the thrombosis on the basis of the body produces fibrin split products. And a DIC picture can result in thrombosis or bleeding, depending on the consumption of clotting factors and platelets. And these, of course, can be measured by prothrombin time, partial thromboplastin time, platelet count. What are the symptoms? They can be mild and flu-like, or you could have a serious infection with systemic sepsis, organ failure and death. Pneumonia and respiratory failure commonly occur, as well as deep vein thrombosis with swollen, painful legs or arms, eventually leading to the post-thrombotic syndrome if the patient survives the illness. Pulmonary emboli can result in respiratory failure and death or chronic pulmonary damage down the road after recovery. Stroke with paralysis and death have also been observed. We realize that the presence of additional risk factors compounds the likelihood of a poor outcome in these patients. And this COVID-19 picture mimics, if you will, Virchow's triad. And these are the three factors that are associated with especially venous thrombosis, and stasis, endothelial dysfunction, and coagulopathy are all essential hallmarks of this disease and can result in a variety of problems. One of the things that's important to remember is that venous thromboembolism or arterial thrombosis is seen in nearly 40% of ICU patients compared to only 2 or 3% on the ward. So getting into ICU connotes a serious escalation of the disease, whether or not they actually have to be placed on respirators. Remember that COVID-19 is an endothelial illness involving the systemic vascular tree. And investigators have postulated that the lung environment is prone for local vascular leakage leading to angioedema, as can be seen in this cartoon. They hypothesize that a bradykinin-dependent local lung angioedema via bradykinin receptors is an important feature of COVID-19. Blocking these receptors and inhibiting kallikrein activity are postulated to have an ameliorating effect on early disease and might prevent acute respiratory distress syndrome. In addition, this pathway might indirectly be responsive to anti-inflammatory agents. And in that regard, a number of investigators have employed early and heavy dose corticosteroids to try to blunt this process. Here we see another cartoon which is designed to show the complexity associated with multiple systems activation as a result of the coronavirus problem. Cytokine storm is a key feature of this, and sometimes it's massive and activates platelets and other clotting factors. This can damage the endothelium, and the neutrophils can express tissue factor, which further activates clotting. Neutrophils' extracellular traps can form, and these contain damaged DNA and other products, including histones and chemical mediators, which can together also block and damage the endothelial surface. Reflecting on all of these changes that occur in multiple locations, both in the inflammatory and clotting pathways, one is reminded of the non-anticoagulant effects of heparins and related agents. The polyanionic nature of heparins binds to proteins and is an effective inhibitor of the viral attachment. So looking at all of these various effects, it's obvious that the use of heparin, or low molecular weight heparins, are one of the cornerstones in trying to blunt the side effects of this disease and also block the pathways, both of inflammation, complement and kallikrein, as well as clotting, fibrinolysis, and platelet activation. We know that when surgery is introduced into the picture in the presence of this virus, that the result can be a very, very serious and, if you will, an explosive picture. Let us take a look at the Caprini score, which is a way to evaluate these patients, which I think is a very essential element. And some have said, why bother to do this? Since all of these patients are at high risk, so we need to put them all on heparin. But there's a matter of degree, and there are some very important aspects to be considered. So when we take a look at the Caprini score, it's a thorough history and physical composed of 40 elements. And we know as the number of elements or risk factors goes up, the incidence to DVT increases. We also know that risk factors have different powers to cause a thrombosis. Bed rest, for example, is not as powerful a risk factor as a past history of thrombosis or cancer. So that the power of these risk factors also factors into the equation. By combining the power of individual risk factors as well as the number of risk factors, we come up with a score. And that score has been associated in a linear or nonlinear fashion to the incidence of clinical venous thromboembolic events. And here we see a typical pattern in general surgical patients. Now, it's very difficult to collect all this information, and especially I've been told by first-line workers as we have these patients coming in, oftentimes they're very sick, they're an emergent nature. We don't have time to sit down with them and talk about 40 questions. Well, my colleagues in our group have come up with a very important patient-friendly assessment for the disease. And as you know, when you go to the dentist, you have to fill in your health history. And if you're brought to the hospital sick, you're usually brought by the family, and the family can help fill out this form. The form is in multiple languages around the world, and it's in very user-friendly language so that it can be easily completed by the patients. And then finally, once that form is filled out by the patients, then it can be completed by the healthcare provider that's responsible on admission for the history and physical. Now, for surgical patients, it's important to prospectively collect this score. And then in terms of filling it out, we have additional risk factors now that we have the coronavirus. And we score all of those people who are positive with an additional 2 points and add an extra point if the D-dimer is over 2 times normal. Remember, you have to add the surgical procedural risks to that. So the risk of a major colon resection is different than that of a routine appendectomy or a small procedure. The score has to be updated during hospitalization as complications occur. Oftentimes, a patient will come in with a simple problem, let's say an acute appendix, and then post-operatively, the patient will leak, have another procedure, need a central line for antibiotics to be infused, maybe get a pneumonia in addition to that. So the patient becomes from a very low-risk patient to a very high-risk patient. Now let us talk about the surgical procedure, because the surgical procedure is an embodiment of Virchow's triad. And as you know, over 100 years ago, Rudolf Virchow described a triad of factors associated with the development of venous thrombosis. And we know that when the patient is put to sleep, they've given a muscle relaxant in order to intubate the patient, and that causes venous stasis due to calf muscle paralysis. The veins become overdistended because the blood is not flowing out normally, but the arteries are continuing to pump blood in. In addition to that, hypercoagulability occurs not only because of the basic disease and underlying pathology, but also the metabolites of the muscles are being secreted into these dilated venous segments, and there's nowhere for it to go, or the very slow flow out of the leg. And that creates a very sort of witch's brew for producing a thrombosis in these vessels. And that's why it's very, very important to use pneumatic compression during these procedures. And of course, the time of anesthesia and the magnitude of the procedure all contribute to this, if you will, witch's brew. Now, recently we put together some guidelines from the American Venous Forum regarding considerations for prophylaxis and treatment of venous thrombosis. Patients all should be scored on admission and rescored during hospitalization with the Caprini score as we previously described. Baseline blood count, platelet count, prothrombin time, partial thromboplastin time, D-dimer assay, and fibrin split products should be done initially and serial, especially if the patient's developing complications. All patients should receive heparin or low molecular weight heparin. Consider doubling the dose for scores of over 8 or those with multiple risk factors, especially those with a BMI of over 35, or those that have cardiac abnormalities or congestive failure. It's very important to increase the dose under those circumstances. Also, depending on the level of D-dimer elevation and the seriousness of illness of the patient, it may be important to go ahead and escalate that dose of anticoagulation up to a therapeutic level. And this is being done around the country and around the world by multiple investigators. We don't recommend routine ultrasound, but only reserve it for those with specific indications that would change the patient's management, such as a swollen leg, pain, tenderness in the leg that are become extreme. And under these circumstances, then a point of care ultrasound could be done. We advocate that the Caprini score needs to be daily reevaluated along with the labs. And then unfractionated heparin or low molecular weight heparin chosen on the basis of clinical situation, including the bleeding risk in those patients that have organ insufficiency. Sometimes they'll do much better with unfractionated heparin than reduced doses of low molecular weight heparin. Although the Wells score can be used to predict VTE, it does not account for all the comorbidities, but it may be useful to guide therapeutic anticoagulation or duplex scanning under certain clinical circumstances. Post-discharge prophylaxis is absolutely critical. Now let us take a look at several recent cases that my partners have experienced regarding this disease. The first is a 90-year-old male who had a non-healing but very painful foot ulcer with an ankle brachial index of 0.3 and a toe pressure of 20 millimeters. The patient was coronavirus negative. An angiogram was done to see if a non-surgical intervention would be appropriate, and it wasn't. So the patient had to undergo a femoral popliteal bypass, which was successful. 40 milligrams of low molecular weight heparin twice a day was used postoperatively, including not only the hospitalization, but following discharge to an extended care 10 days later. So approximately several weeks after the patient's surgery, the patient was readmitted with coronavirus positive, and this was attributed to a healthcare worker at the extended care facility. And the patient needed to be put on a respirator, was given full dose low molecular weight heparin, but to no avail, and died 48 hours later. An autopsy was done and found that the graft was patent. There was no arterial occlusion, and there was no venous thromboembolic event either, but there was. The next patient was a 57-year-old male who had insulin-dependent diabetes, a BMI of 40, hypertension, sleep apnea, and he was a maintenance manager at a nursing home and contracted the virus. He presented with a 3 times normal D-dimer, and the left leg was very dusky from the knee to the foot. Full anticoagulation with low molecular weight heparin was administered, as well as fibrinolytic therapy in 2 courses. A palpable pulse in the groin and popliteal was documented after the fibrinolytic treatment, and this tended to improve during the week of hospitalization with the low molecular weight heparin. Unfortunately, below the knee had become ischemic and gangrenous, and a below knee amputation was done in this patient in a negative pressure OR. At the end of the procedure, the physician dissected the specimen in the OR that was removed. It wasn't sent to pathology, avoiding any additional transfer of the virus. And a thrombosis of all 3 tibial arteries was noted, but the veins were patent. The patient was recovering slowly and the stump healed, but the patient has remained in the hospital as of this writing due to a bacterial pneumonia. So we understand that surgical procedures in COVID-19 patients are very serious, and not only because of the nature of the disease with all the thrombotic elements, but in addition to that, all the risk factors that the patients bring to the table. And as a result of that, an increased incidence of arterial thrombosis, deep vein thrombosis, pulmonary emboli, stroke, or fatal thromboembolic events require careful risk assessment and appropriate thrombosis prophylaxis for the at-risk period, especially following discharge. Now, here is an expression given to me by a Maine friend who was a well-known dentist. And it's never kill a friend, never treat a stranger. Now, what's going on here? What did he mean by that? Well, what he meant was that it's important to perform a thorough history and physical to every patient you meet, so that that gives you knowledge about this patient that's the same as your knowledge would be, or even more than a good friend. So, of course, you would never treat a stranger, and you would never hurt a friend. So I'd like to thank you very much for listening to this presentation, and I would encourage all of you to visit my website at venusdisease.com for more information, and have a wonderful day and stay safe. Thank you very much.
So thank you very much for listening to that.
Thank you very much for everything. Thanks. Excellent presentation.
That since that video was created, things have continued to change somewhat, and it's amazing what a fast-paced process this is. But I can go ahead and show the supplemental slides. I have a couple supplemental slides that I'd like to show, and then we can have questions if that's
okay. You want to go ahead right now?
Yes.
Okay, let's go through.
So I'd like to just present some additional information based on the questions I received from you all so far. Plus, we've also modified the Caprini score, and I wanted to update that with you as well. And what we have decided to do is to encourage everybody to do a score. And there's a new video I'm preparing for patients. Everybody should do the score today, now, and know that score. Keep it in a safe place. Your family needs to know it, because if suddenly you get sick and suddenly you come into the hospital with a major problem related to, especially to this virus, there will be not a lot of time to go through a history and physical. And having that information, the baseline information about what the unique characteristics are of the individual patient, would really be important. And that would affect what's going on with your treatment. And so we feel that there's even patients at home that, if they have a high score, should receive thrombosis prophylaxis. And so if the patient is coronavirus positive, they get a score of 2. Now, if the patient, let's say, is sitting at home with age over 60, BMI that's high, maybe some other comorbidities, diabetes requiring insulin, and you add the coronavirus, those patients should probably get some prophylactic low molecular weight heparin immediately, even though they're an outpatient. Now, I would also like to say at this point is that we're very honed in, of course, on this disease from a clotting standpoint, because it is basically a disease which is highlighted by thrombosis. But that's only a small part of the picture. If you remember that cartoon I showed with all the systems that are activated, we realize that what's going on here, and it really is a concept that was originally introduced by Dr. Oscar Ratnoff, who was a famous hematologist from New York, by the way, and his father was a New York pediatrician. And when Oscar was born, the pediatrician told Oscar's father to let him die because he was too frail. And Oscar kept him going with hot water bottles. Now, is it an accident, or maybe even a divine intervention, that Oscar went on to describe the clotting cascade? He also discovered factor 12 in a patient, John Hageman, but he also came up with a very important concept that he published in 1970. 71 actually, and it was called the tangled hemostatic web. And what he said was that with the activation of factor 12 from the contact activating pathway, it activated platelets, coagulation, the fibrinolytic system, but also activated C1 in the complement system and kallikreins, the kininogen to kinin in the immunologic system. So that contact activation not only triggered clotting and fibrinolysis, but also complement and kallikrein. So as we look back, and as I give you all this lecturing about increasing the heparin and so on and so forth, that's all well and good. But as you probably all realize, we're going to need a very sophisticated cocktail to help attack this disease. It's going to involve not only clotting, but the platelets, fibrinolytic systems, and also, most importantly, the inflammatory pathways and the immunologic pathways. So that having been said, getting back to this slide, if the patient is positive, we give them a score of 2. If they have symptoms, it goes up to 3. And if they have a positive D-dimer, 5. And we update that during hospitalization. And I wanted to present that clarification because we've just decided to go ahead and do this based on further considerations and further data. And I would like to say another thing here, which is I find absolutely astonishing, and I put it under the category of human nature. In 1991, thanks to a very brilliant fellow, as well as another individual who was a medical resident, they scored 1,000 patients out of my hospital, and they showed how many of those patients were at high risk for blood clots, and they showed the value of the Caprini score. That was in 1991. As of this last month, finally, as a result of the coronavirus, our hospital instituted the Caprini score and put it in the electronic record and is automating it. So it's very interesting that it takes time to develop these things, and they're certainly not for everyone. And I also want to say regarding the scoring that there are many roads to Rome. And I am naturally, I've been devoting all of my energy to looking at and developing and analyzing the pitfalls associated with this score. But as you all know, there's some other very good scores, especially in medical patients. The Padua score, even the Kucher score, which started it, the Improve score, and the Improve with D-dimer score, and the Geneva score, and the British Health NIA, British Health Industries National Health Scoring System. There are many different scoring systems. And I would say that to all of you, I don't know what scoring system you're using, but you have to use whatever the hospital is comfortable with. Look how long it took my hospital to be comfortable with one score. Now, what I would like to do is also to highlight the excellent work of Alex Spiropoulos, because Alex Spiropoulos has done some beautiful work with the Improve plus D-dimer score, and he's validated that in patients after discharge, medical patients, and shown a dramatic lowering of venous thromboembolism, and also which patients should get post-discharge prophylaxis. And 2 of the new oral anticoagulants, rivaroxaban and betrixaban, have been shown to be effective for up to 39 days. Now, all of that having been said, if you have taken all these years to get the Caprini score in place, now you're going to have to try to teach the hospital as an additional score. So it gets kind of confusing. So whatever scoring system you're using, I would encourage you to stay with it, because there, as I say, many roads to Rome, and there's a lot of ways to get to the same endpoint. Now I'd like to address something regarding the questions that I was asked the other day and sent to me. And I have I've taken a look at some of the literature, and there is some literature emerging in this. And there's some initial reports that this was a report of COVID-19 positive patients infected in the third trimester, and their clinical findings were similar to those in non-pregnant patients. Remember that, as you know, pregnancy increases the risk of thrombosis, and so does it, of course, then adds the virus adds to that. Fetal distress and preterm delivery were seen in some cases, especially in those patients that had comorbidities. All but 2 pregnancies were cesarean deliveries, and no evidence of in utero transmission was seen. It also is unknown at this time whether the SARS-CoV virus can be transmitted from the mother to the fetus, and breastfeeding can be instituted after the mother is no longer considered infectious. And no recommendations were available regarding low molecular weight heparin prophylaxis. And as you know, there's controversies in the literature already about pregnant patients who've had a history of thrombosis, about what you should do. You should protect them with low molecular weight heparin or not. And then there's those patients that have a history of the antiphospholipid antibody syndrome. Should they be put on aspirin? Should they be put on aspirin and low molecular weight heparin? I wish I could answer all those questions, but they are controversies. Now, in addition to that, sorry about that, operator error. So here is a slide that I just reprinted from one of the publications that just came out. And I did that for especially for the chief of obstetrics and the obstetrical physicians that are involved in this disease. And they can look these things over, and it gives them the principles for management of pregnant women for Corona-19, as far as we know right now. Then I would like to go out on the limb and present what I would call Caprini speculation. And please do not look at these as guidelines. They're simply looking at this problem from the eyes of a clinician who's been around for a long time. And as a result of that, I've gained a lot of experience, but I've also committed a lot of mistakes. And so I have a lot of scars. So taking all of that in context, here we go. Perform a Caprini score, modified Caprini score in all of these patients. And that includes the new criteria for coronavirus. All of those patients should receive low molecular weight heparin if they have a score of under 8 at a standard dose, and that should be continued for 7 to 10 days postpartum or post C-section. I would double the prophylaxis for scores of greater than 8 or a BMI of over 35 or cardiac failure, impaired ambulation, or positive D-dimer. And I have this in another video, but it's important to understand that getting up and going to the bathroom is not ambulation. You've got to be able to walk 30 feet using both legs. And that comes out of the Metanox trial, where they did a subset analysis by Professor Alpesh Amin, and he showed that from the data from patients who were treated all over the world, randomized to low molecular weight heparin or not in medical patients, there was a 19% incidence of patients having a DVT if they were non-ambulatory. But if they could walk 30 feet or 10 meters, they cut that rate by 50% to less than 10%. So it's a very important thing to consider with ambulation. And then, of course, we do not recommend the DOACs for this. After discharge, perhaps you could maybe use them. There's some indirect evidence, as I talked about, with the improved score. But in general, during hospitalization or during the acute phases of the disease, those new anticoagulants are not recommended. And again, toxemia is a special problem, and it's very difficult. I think it's a case-by-case basis, whether you're using heparin, low molecular weight heparin, aspirin, and you have to individually assess these patients. One thing I would like to say, which has stood me in good stead over the many years I've treated patients, is what I would call my secret anticoagulant weapon. There will be many situations where the patients will be at high risk of bleeding, and you're deathly afraid to give them a dose of anticoagulation. Well, my secret weapon involves don't give them any injections, because once you give an injection, you can't take it back, number one. And number two is if the patient becomes shocky, you're never sure of how much of that drug is getting into the circulation. So I like a intravenous heparin drip. Now I know with COVID patients that may increase the healthcare providers to certain additional risks, but it's very, very important to people who are at higher risk for bleeding. And that holds true in a lot of obstetrical situations. You know, I sympathize with the obstetricians because they have hours and hours of boredom punctuated with moments of terror. And so some of these terror moments are around patients that should be getting anticoagulation, but also have a high risk of bleeding. And you also, of course, have to consider the fetus at all times. So an intravenous drip is nice. You can start it very low. And if anything untoward happens, you can shut it off. And so I think that that's an important thing to keep in mind. And another thing is that sometimes they will say, oh, well, this patient's at high risk of bleeding. But then 2 days later, reevaluate the patient. Are they still at high risk of bleeding? So just remember that that's not an all or none thing. So with that having been said, I'd like to thank you very much for inviting me into your country and your home. And I'll be very happy to try to answer some questions. Thank you very much for your attention.
Okay, thanks, Professor Caprini. It was, as always, an excellent talk. Thank you very much for everything. I will just open up the panel right now for some questions and comments. I will start with Lowell about if you have some remarks, please, my co-moderator. Is something special that you want to address, Lowell?
Thank you, Victor. Joe, excellent lecture again. I've listened to it twice, and I think everybody should listen to it at least 2 or 3 times. Joe, I think you raised a lot of good points with the Caprini score. Well, one question I have, after the patient is COVID negative, been positive, is negative, we're 6 weeks out, and that patient needs surgery, do we still give any credit or points to COVID patient that were previously positive? Would we add 2 points to a Caprini assessment? 6 weeks out, Joe.
Yeah, that's a wonderful question. I would say that when someone has a DVT, I don't know the answer to that. But if somebody has a DVT in the past and they recover from the DVT, you still count that going forward in the future. So I would add the 2 points to that patient just to be on the safe side. And it may be that once they have it, they can't get it again. And so that may be academic. I don't know, but that's what I do right now.
Last question to you would be, the use of dipyridamole and aspirin seem to be gaining some traction. What do you think about that?
I'm very much in favor of it because remember, this is a disease involving thrombosis with all those multiple pathways. And we don't see a whole lot of bleeding. The one place where there's been some bleeding has been in situ hemorrhages in the lungs. And that's true. But I would say that if you want to start experimenting with that, you could go back to my trick of, instead of giving them heparin shots, use the intravenous heparin drip, get those antiplatelet and drugs on board, and then see what happens. And if the patient is experiencing any bleeding, he can always back off on the heparin. But I don't think you're going to see that. I think you're going to see that it probably might be somewhat helpful. And I think that one thing in the back of my mind is very important, and that is hitting them early and hard. Because if you can start to blunt some of these reactions very early on, then it seems to me that that might eventually help out with the disease.
Thank you, Joe.
Thank you very much.
Okay, we'll go back to Dr. Professor Machain. Is to remember, is a vice dean, the chairman of the department of Department of Surgery in the University Hospital here in Paraguay. Gustavo, you want to address something? I would, if you speak English, go in English, or en español, yo te traduzco sin problema.
Okay, gracias, Victor. Professor Caprini, excellent conference. Amy, Víctor, si podés decirle, tengo algunas cuestiones, algunas preguntas. La primera sería con respecto al tratamiento antitrombótico. de los pacientes pediátricos con síndrome de Kawasaki símil, si tienen alguna experiencia con respecto a eso. Segundo, en el lado...
Uno nomás. I will just address, vamos uno por uno. The first one is just talking about Kawasaki disease in pediatric patients. If you have experience regarding about how will be the treatment in those pediatric patients with thrombotic disease and Kawasaki.
I'm sorry, I missed part of that. Could you repeat that, please?
Yeah, he asked about Kawasaki disease in pediatric patients, and if you have some idea how we will be able to treat them.
I really don't have any experience with that, so I can't give you any good advice.
Okay, next one, Gustavo.
Sí, la pregunta con respecto a la cirugía en los pacientes oncológicos. Algunas pautas de tratamiento que él nos pueda sugerir con respecto a el paciente oncológico que se realiza cirugía y que durante la internación, ya sea en la unidad de cuidado intensivo o en otro sector del hospital, adquiere la infección. ¿Algunos cuidados, alguna experiencia y qué nos puede recomendar?
What we can do regarding about cancer patients who require surgery and they come up with no COVID, and then they develop the disease when they are in house and they are in the workup for the treatment. They would like to know what are the guidelines for those patients.
Well, first of all, cancer patients represent a nightmare because that for several reasons. First of all, delaying proper surgical treatment in the cancer patient can be very, very disastrous. So that we have on one hand, and these are patients that need to go to surgery now to start. The patients that have to go to surgery and are diagnosed with the coronavirus, the latest data is very, very troubling. And up to a quarter of those, a lot of those patients, I can't remember the figures exactly, but a lot of those patients may get clots, even up to half of them, and up to a quarter of them may die despite what's done. So you have to be very, very careful. And so as far as a cancer patient would go, I would do the same thing as a patient that develops an acute DVT and has, let's say, a cancer of the colon. Or if you think you can wait 4 or 6 weeks for the surgery safely, then I would go ahead and do that and wait till the acute phase of the coronavirus is over. And you have to balance operating early on a positive patient against the severe incidence of venous thromboembolism and death. So that's the first thing. The second thing is that I think is also a problem is that now you're working the patient up and they develop the virus, but they necessarily haven't gone to surgery. I don't know what to do with these patients, but I would try to perhaps, if it's possible, to treat them with chemo or radiation instead of taking them to the operating room. Now, it may turn out that that may be just as bad or worse than taking them to the operating room. So I think that we're in a really difficult situation there. And I really don't know what the best thing is to do. Each case has to be individually analyzed. Very impossible situation.
Gustavo. Profesor Machain, abrirle su micrófono, Manuel, por favor. Abrir tu micrófono, Gustavo.
Sí, gracias. Si podés traducir la contestación del doctor Caprini.
El profesor dijo que es una situación muy difícil en el punto de vista de los dos casos. En primer lugar, si podés esperar con seguridad para que 4 a 6 semanas los pacientes que tienen cáncer los pueda tratar una vez que haya pasado el efecto del coronavirus, en ese momento lo haces. O si no, tomás como los pacientes que tengan trombosis venosa profunda, o sea que los tratás en su totalidad con esa guía de práctica, como si fuera un paciente que desarrolla trombosis. Entonces, en esos dos casos, tenés la solución a ese problema.
Ok, gracias. No hay más preguntas.
Okay, thanks, Professor Machain. I will go for the next one. The OBGYN chairman of department, Dr. Bataglia, the mic is in yours, and you have some developed already from the Professor Caprini. You have some questions. I will wait for your questions.
Sí, antes que nada, yo creo que gran parte de las dudas que había ya las ha respondido con los dos últimos slides. Ahora, teniendo en cuenta que el embarazo es un estado fisiológico de procoagulación 4 a 5 veces más en relación con una mujer no embarazada, ¿verdad? Dentro de la escala, me gustó el slide de la escala de Caprini donde él agrega embarazadas positivas, asintomáticas o no, y el dímero D. Sabemos que el dímero D está muy aumentado en las embarazadas. ¿Cuánto consideran su escala para darle 5 puntos en una embarazada el nivel de dímero D?
The professor, he just asking regarding about the D-dimer in pregnant women. If you score them, how much do you want the D-dimer go up to just give a change in your grade of your scale in pregnancy woman?
Again, I don't know the answer to that question, but I would start by saying that if the D-dimer, if the D-dimer is twice normal, then, and that's age adjusted, of course that wouldn't apply because all the patients are less than 50 usually. But I would say that if the D-dimer is at least twice normal, then I would consider doing that. And what I would also say is, in order to answer this question, I would go ahead and start doing D-dimer levels in your pregnant patients at the time of delivery when you're going to need to do something, and see what their baseline is in your practice, in your area. And then based on that number going forward, do it for a month or so and see what is the average D-dimer elevation in your average pregnant patient who doesn't have the virus. And then I would say, then I would use that as the baseline and then use it, double that as increasing their score.
¿Entendiste, Ramón? Dice que quiere que hagas un pre en todos tus pacientes que tienen, que como vos decís, que el D-dimer va a estar alterado y aumentado por el embarazo. Entonces necesitas tener una línea de base en todos y de ahí en más ver cuánto es el aumento. Si tenés una línea de base para saber cuánto es el D-dimer en todos los pacientes, entonces de ahí, cuando sea el doble, vos vas a poder cambiar la escala.
O sea, es lo que generalmente se recomienda, ¿verdad? Como son valores altos, tener un valor de inicio, ir comparando en relación a la evolución.
Eso es lo que te respondió.
Gracias.
Pero necesitas comenzar con el D-dimer, ahora ya que estamos en una crisis muy grave y no podés saber quién se va a volver cero positiva, entonces necesitas tener eso para tener un esquema de qué va a pasar en el futuro.
¿Y en el prequirúrgico?
Okay, he would like to know also if in the pre-surgical moment for the OBGYN patients, do you think that we should ask for the D-dimer too?
Absolutely. Yes. Yes, I think that's very important.
Necesitas tener una hora preoperatorio, vamos a tener que pedir a todos de D-dimer en tus pacientes, Ramón.
Y que le tenemos acá al vicedirector, ¿verdad? Los directores al vicedecano.
Ajá, así que va a tener que hacerle únicamente el esfuerzo. Bueno, ¿alguna pregunta más, Ramón?
Si él recomienda la anticoagulación en las COVID asintomáticas, porque generalmente las guías que manejamos es asintomáticas o no, leve, moderada o severa en toda anticoagulación.
Okay, in pregnant woman, COVID with no symptoms, do you recommend anticoagulation?
If the patient is pregnant
Yeah.
and the patient The
Last
patient,
COVID.
the patient is pregnant, and the patient, for some reason, has had a test, even though they're not symptomatic, and the test is positive, the answer is yes. And you might even, then if the patient is symptomatic, then I would double the dose of anticoagulation. And this is in the pregnant patient before delivery.
Ok. ¿Alguna pregunta más, Ramón?
Muchas
Profesor
gracias,
Batalla.
agradecer la excelente presentación y muchas gracias por la invitación y a todos mis colegas que están participando también en acompañarnos.
Ok. Muchas gracias, profesor Batalla. Cualquier cosa a las órdenes nuevamente. Seguimos con el próximo panelista, que es el primero en la lista, que es el profesor Mesa, que es el de la... ¿Está el profesor Mesa? No. Seguimos. Profesor San Martín.
Sí, estoy presente.
Ah, no te he
doctor
visto,
Víctor
profesor.
Canata.
Perdón.
Aquí estoy.
Profesor Mesa, de pediatría. ¿Alguna pregunta, algún comentario?
Sí. It is a great honor for me to have been invited on this meeting and also privileged to form this table with such outstanding teacher and guests. Thank you, Dr. Caprini.
Thank
It
you.
is an excellent conference. And I apologize for my loosey English for all.
Better than my
And
Spanish.
if you don't mind, I'm going to talk in Spanish, and I will to refer in my language. Doctor Canata, si le puedes traducir, por favor. Entonces, sí, realmente, más que nada, quiero acotar algunos puntos. En primer lugar, que las plaquetas juegan un rol fundamental en la respuesta inmune innata, en lo que se refiere en particular a los virus, al coronavirus en este caso, provocando un extenso daño inflamatorio y una respuesta endotelial vascular, y esto es lo que realmente va a llevar a una inflamación sistémica y vascular, partiendo de esa base. Entonces, la pregunta que quería yo hacerle al doctor es si es que la escala Caprini es aplicable en primer lugar a pediatría.
Okay. He asked about, he said that the platelets are playing a big role regarding about the thrombosis and all the trouble that we have. And he concerned about if the Caprini score is able to apply to the pediatrician patients.
What?
Pediatric patient and Caprini score.
Yeah, I'm sorry. What about the patient on the Caprini score?
Yeah, he will, for pediatric patients.
Oh, pediatric patients. I'm sorry. Pediatric patients. Well, of course, we don't have a lot of data in pediatric patients, but what I would say is that, remember, the Caprini score is a name attached to what is a thorough history and physical. So you need to do a thorough history and physical in the pediatric patient. And if that patient has a cancer, has some developmental anomaly that is associated with increased incidence of blood clots, then under those circumstances, that patient should be treated with prophylaxis. So that until we have more information, I would use that, especially, remember, especially for patients, pediatric patients that are that need central lines, pediatric patients that have malignancy. And these are very high risk groups and they deserve prophylaxis. You don't really need a Caprini score in order to provide the proper prophylaxis. Now, what I would like to say at this point, and I'd like to go back to what I said for my colleague from obstetrics and gynecology and the others, and in surgery, please keep track of your results. For example, in obstetrics, if you're going to start doing these tests, record the tests, record the outcomes, so that you can help teach us by your example what we should do with these situations, all these questions. Most every question that was asked, we don't have an answer for. But by all of us collecting our data and putting it together, then we're going to make progress. And I would point out to the wonderful work Manuel Monreal has done, and with all of the countries around the world, including yours, of course, with the COVID-19, with the Varices database. And that's what we really want to know. And I think that one of the things that we overlook here in America, some of us, is that we all stick to these sort of very elegant, well done, randomized, prospective trials with a high degree of certainty and so forth. But they're only in average risk patients because you can't put very high risk patients in these trials. So we have to turn to things like the Varices database for real world data. What does the real world doctor do with the real world patient? And as all of you know who take care of patients, you're doing that every day. You're making individual decisions that are not in the guidelines because there are no guidelines. And the answer is, please keep track of all of your results so that you can go back and take a look and see how successful or not successful a particular approach may be.
¿Alguna otra pregunta, profesor Mesa?
Sí, tengo en realidad una segunda pregunta, que es en relación a que si es que no tenemos la capacidad de medir dímero D, sobre todo en un ambiente hospitalario, si es que él qué opina en relación a la medición de ferritina y fibrinógeno.
Okay, if you are unable to get the D-dimer, what about if we taking care of the ferritin levels and fibrinogen levels to take care of and see if we can grade them instead of D-dimer? Do you have any experience with that?
Yes, so that's a very good question because we know in the COVID-19 that early, not only the D-dimer goes up, but remember that the D-dimer is actually a part of a split off of the fiber. It's like a fibrin split product. So the next thing I would do is do a fibrin split product assay in the patient and do a fibrinogen level. And the two of those should give you a good guide, if you can have D-dimer, of that there's something going on. PT, prothrombin time and partial thromboplastin time and platelet counts early in the disease are usually pretty normal. So that's not going to help you. Now, there is some data with ferritin levels, but I'm not experienced enough with that to tell you. But I will tell you that where I would go if I couldn't do a D-dimer would be to do a fibrin split product assay and also do a fibrinogen level. And if that fibrinogen level is up and the split products are up, I would treat that as if the patient is D-dimer positive.
Okay,
Thank you, Dr. Joseph. ¿Podría traducir, por favor, para el auditorio,
Sí.
doctor Canata?
La historia es esta. Él lo que dijo es que el fibrinógeno es parte del producto de la degradación en el trastorno de D-dimer. Entonces, lo que les pide fundamentalmente es que pueden medir el fibrinógeno sin ningún problema y si está alto lo trataría en la misma forma como si tuviera un D-dimer positivo elevado. Y también de que estos pacientes necesitan un chequeo desde entrada de su ingreso para poder evaluarlos a continuación cómo va cambiando esos niveles. Sobre la ferritina, dice que no tiene experiencia, pero es un hecho que es consumida en el momento de que comienza el accidente trombótico. Pero con el fibrinógeno te dice que es prácticamente lo mismo que la medición del D-dimer.
Perfecto. Gracias, doctor Víctor.
¿Alguna pregunta más, profesor?
No, gracias por...
Ok, paso al profesor San Martín, que es uno de los más envueltos en esta situación. Profesor San Martín is a pneumonologist, profesor Caprini. Ok.
Buenos días, muchas gracias. Una consulta relativa al tratamiento. He encontrado en varios artículos que colegas utilizan heparina no fraccionada prefieren heparina no fraccionada con respecto a, digamos, dosis terapéuticas de heparina de bajo peso molecular. Quería saber, para el tratamiento a pacientes con COVID, ¿verdad? Quería saber si hay una experiencia al respecto del profesor, ¿verdad?
What do you think about low molecular weight heparin instead of non-fractionated heparin for the patient who has COVID? What is your first choice of treatment on those patients? No regular heparin or low molecular weight heparin?
The first choice is low molecular weight heparin because it's been shown in other thrombotic situations to be more effective than unfractionated heparin. That having been said, I wouldn't hesitate to use unfractionated heparin when there is an increased risk of bleeding. And especially with, as we know in pulmonology, first of all, the beautiful interface between the alveoli and the endothelium. It's magic. That's where the exchange occurs. And this disease has a predilection to attack that interface. And as a result of that, one may get hemorrhages in that area, but also primary pulmonary thrombosis can occur. And so I would prefer, when possible, to use the low molecular weight heparin because I think that will be more effective in treatment under those circumstances.
Low molecular, heparina de bajo peso molecular, profesor, y alguna pregunta más o algún comentario más que tengas.
Simplemente agradecerles a nuestros invitados, muy agradecido por su gentileza, y se me escapó el arma secreta que comentó el profe Caprini. No pude traducir íntegramente, que solo eso se me escapó.
Just to address you, what is your secret weapon in again?
That's the unfractionated heparin drip, starting with 250 units per hour and gradually increasing and carefully observing the patient.
Cuando tenés alguna duda, siempre la heparina no fraccionada es la que te va a ayudar. Si no hay duda,
Okay, thank you very much.
Okay, let's go for the next one. Is Professor Ruiz Diaz, the chairman of the Department of Vascular Surgery. ¿Algún comentario, profesor Ruiz Díaz, si puedes abrir tu micrófono?
Víctor y estimados profesores, ¿verdad? Muy interesante la charla, muy aclaradora en casi todos sus puntos. Solamente no sé si es una pregunta o
sí,
algo más de información en cuanto a los pacientes, ¿sí? En cuanto a los pacientes, catálogo, el esquema con el score de CAI alto, si consideran
no se escucha bien, no se escucha. Jorge, repetimos la pregunta, por favor.
Sí. En cuanto a los pacientes generalmente graves, con score de Caprini alto, si se considera el uso de fibrinolíticos y qué resultados han tenido con ellos.
Okay, he will just to know about if the patient has a high Caprini score and is with ischemia in the leg, what about the use of fibrinolytic agents in those kind of patients?
Yes, that's a very important question. And as in the patient that I showed that had leg ischemia and was positive, I would certainly use local fibrinolytic therapy. And I would do it the same way as the heparin, start with a very low dose drip and perfuse locally rather than systemically, and then observe the patient. And I think that and this holds true for ischemic limbs, not so much for pulmonary emboli unless there are signs of right heart strain or signs that you would normally use lytic therapy with severe right ventricular dysfunction. But these, for ischemic limbs, I certainly would go to very low dose fibrinolytic therapy. I would not hesitate to do that.
Profesor Ruiz Díaz dice, bajo nivel de agente fibrinolítico va a ayudar mucho en el paciente.
Gracias. Muy interesante la conferencia y gracias al profesor Caprini por sus experiencias.
Gracias, profesor Ruiz Díaz. Vamos a seguir adelante. Profesor Javier Escobar, vicedirector del Hospital de Clínicas. Le escuchamos, profesor. ¿Alguna pregunta o algún comentario para el profesor Caprini?
Sí, buenos días a todos. Encantado, profesor. Muy interesante la charla. Una duda en cuanto al tiempo de anticoagulación posterior al alta y si se ven reingresos por tromboembolia después de las 4 semanas de externado del paciente.
Okay, he would like to know if there is some kind of thrombosis events after the patient was discharged from the hospital. If you know about that, how you will treat them.
There are a number of reports of post-discharge events. Patients who've had the virus, they've survived, they've gone home, and they've developed pulmonary emboli. And I was noticing that recently there was a Harvard-based webinar, and they presented all of this evidence-based data from the pre-COVID era and tried to apply it to the COVID era. And one of the things they said was that they didn't recommend post-discharge prophylaxis in these patients that survived the COVID virus. And then in the next sentence, they acknowledged that the number of their patients were coming back with clots. And I said to myself, it's so hard. And with everything you have to put, I'm certainly not being critical, because that's one of the worst things, and that's led to a lot of problems in this country now. And I'm not trying to be critical, but you have to put your feet in the shoes of the other person. And if you're a very academic, data-driven person, it's very hard for you to go ahead and speculate, like I am as a clinician, saying that those patients are getting clots, we don't have evidence, so we've got to make something up. And I think that what we have seen, so let's take a look at that literature. In 2008, Professor Arcelis, who worked with me, presented a trial from the Varices database showing that 77% of people got their clots after they went home from the hospital, and 55% of them after anticoagulation was stopped. Despite that, the guidelines since that time recommend that if a medical patient without the COVID is discharged, that you can stop their anticoagulation. And so that data didn't make sense. And now if you add the COVID to the picture, it further doesn't make sense. And so what I'd like to say is that you need to treat these patients when they go home. We suggest the algorithm that if their D-dimer is positive or their score is over 8, that you go ahead and treat them with at least 6 weeks of prophylaxis. And the other thing I wanted to say is that if we have time, I'll show a couple more slides, but I want to make sure that I get through the questions. But that's a very important question, and post-discharge is very, very important.
Okay, ¿algo más, profesor Escobar? ¿Alguna pregunta más?
Nada más, profe, pero si me traduce la respuesta.
A todos hacerle su profilaxis en alguna forma en la forma en la cual son dados de alta, todos deben de tener una profilaxis completa cuando van de alta, con DOAC o con heparina de bajo peso molecular, depende de lo que ustedes decidan. Por eso
Gracias.
ocurren los eventos trombóticos. ¿Ok? Profesor Marcelo Persani, nuestro jefe de urgencia.
Bueno, buenos días, muchas gracias por la invitación. Sí, yo solamente una pequeña pregunta práctica tengo en cuanto a la utilización de la escala en los pacientes que llegan a la urgencia. Nosotros tenemos un retraso en el diagnóstico de pacientes COVID, ¿verdad? Si es positivo o no, y llegan pacientes muy graves con problemas respiratorios graves que llegan a la falla respiratoria, y en ese periodo en que nosotros no sabemos si es COVID todavía al paciente, le agregamos los puntos como si fuera COVID e iniciamos la anticoagulación antes de tener el resultado, o necesariamente tenemos que tener el resultado positivo del COVID para agregar esos puntos de riesgo de anticoagulación en la escala.
Okay, this is a question from Professor Marcelo Pedersani, Professor Caprini. The idea is he is the chairman of the emergency room and he is in trouble with the patient who just came in with the COVID disease. And they have some delay regarding about if the patient is or not COVID since the results are not coming. He would like to know if you are thinking about if the patient is COVID or will develop the disease and you will be in trouble with that when you start doing the prophylaxis for those patients?
Very good question. My answer is immediately. Now, you should be able to have an educated guess as to whether the patient is positive. That educated guess can be based on their clinical picture. If they come into the emergency room, and of course, if it looks like they have the disease and you ordered the test, that's enough information to start. Secondly, you can always do a fibrinogen level. Fibrinogen level can be done very quickly, and a fibrin split products level. And if they're up, then you know that patient probably has the disease. And I would go ahead also and do the score, and you might even have a patient in the emergency room that you don't know the final answer yet, that you're giving double the prophylactic dose to because they presumably have the illness and have comorbidities, particularly those with cardiac problems, lung problems to begin with, smokers, patients with asthma, patients with elevated BMI, and so forth.
There is another, dice que desde que comienzan a internarse y vos tenés alguna duda, iniciar la profilaxis y hacer tu cobertura según tu esquema de Caprini. ¿Alguna pregunta más, profesor Pedersani?
No, muchísimas gracias por la respuesta y excelente la charla del profesor Caprini, y espero continuar escuchando lo que dicen los compañeros.
Ahora vamos a tener el aspecto del doctor José Alderete. El doctor José Alderete, Professor Alderete is a cardiologist who is working with us in the cardiology department. ¿Alguna pregunta, profesor Alderete?
Yes, congratulations, Professor Caprini, for such an excellent conference. Realmente la mayoría de las preguntas creo que fueron ya respondidas. Solamente quería enfatizar algunos conceptos importantes que me parece, sobre todo de medir continuamente los factores de riesgo y tanto el dímero D como el recuento de plaquetas es sumamente importante, teniendo en cuenta que la mayoría de las complicaciones trombóticas ocurren luego de la primera semana de internación. Es infrecuente ver ya de entrada estas complicaciones tromboembólicas, sobre todo en pacientes graves, ¿verdad? Entonces la importancia de medir continuamente durante la internación es sumamente importante. Y obviamente tener siempre en cuenta que una de las complicaciones de estos eventos tromboembólicos es el tromboembolismo pulmonar, ¿verdad? Sobre todo en los pacientes que están graves en la unidad de cuidados intensivos y que tenemos que tener siempre presente, ya que muchas veces estos pacientes están intubados, de por sí están hipoxémicos, de por sí están taquicárdicos, entonces es importante siempre tener en mente la posibilidad del tromboembolismo pulmonar en estos pacientes. Realmente excelente esta conferencia. Muchísimas gracias por la invitación, por poder ser parte de esto y bueno, solamente quería acotar estos comentarios y thank you, Professor Caprini.
Thank you.
Angelo Scuderi, we give some closing remarks. Profesor Scuderi, te escuchamos. Algunos comentarios de Brasil también para cerrar todo.
Yes. First of all, I'd like to congratulate Professor Caprini for excellent presentation. Fantastic.
Thank you. Gracias.
Grazie. Do you speak Italian, no?
No.
Parlo un po' di italiano.
My parents were first-generation Americans, and first-generation Americans were ashamed of the old country, and they didn't teach their children. I really wish I knew Italian, because that in Spanish is very close.
Very close, exactly.
Yeah. But I have great love for the people, so that's more important.
Yes, of course. Well, Professor Cabrini, I liked very much your presentation. I remember, if I don't mistake, the first or the second slide or third slide talk about the hypercoagulation is a defense mechanism to block the virus. It's okay. It's true. This phenomenon, the coagulation, the production of the fibrin is one mechanism of protection.
Yes. Yes. So yes. So this is fascinating. The body, in response to this invasion of this virus, develops fibrinogen to fibrin so that the fibrin can coat the virus and isolate it, so it can invade the beautiful alveoli, and it can't replicate. It sort of traps it. But in the consequence of trapping the virus with the fibrin, it produces not only clotting, but remember that the first stage of clotting is factor 12, the contact activation pathway, factors 12 and 11 and so forth. And so that activation of factor 12, as shown by John Hageman, are responsible for this triggering of platelets, clotting, the fibrinolytic system, the complement pathways, and the kallikrein pathways. And so that's why this is such a complex disease.
Yes. Well, I have one question. After that, one comment. If you have experience in replace the heparin from aspirin and platelet aggregate,
right?
Antiaggregation. If it's possible to use this.
Yes, I would. Yes, it certainly is. And I would say that one of the things that we know is that there are certain categories of patients that you can almost predict are going to die. Example would be, first of all, you operate on a patient with the disease. We know that up to 25% of them, I believe it's 25%, it's a very high percentage, will die afterwards, regardless of their treatment. Patients that are in ICU, they're prone, they're on respirators. They're already on even maybe full dose anticoagulation. Those patients have a very high mortality rate. Those patients, the original study by Tang from China that showed that if patients had signs of DIC-like picture, that the majority of those patients died. So I would say that in the more extreme groups, I would go ahead and use the antiplatelet drugs. And the most important thing to remember is to keep track of your results. And so, for example, let us say that you have full anticoagulation going in a patient in ICU on the respirator. Then you might want to transfer them to a heparin drip, because once you give them the platelet drugs, they'll stay in the circulation for a period of days. So if the patient starts to experience, for example, bleeding, then you can back off on the heparin. But I certainly think that would be the next step. I don't think it's going to be the answer. I think you're going to need to block the complement and kallikrein pathways as well. But right now, it's pretty hard for me to envision a cocktail that includes the antivirals, anticoagulants, anti-inflammatories like steroids, and antiplatelet drugs. That type of a cocktail would be something that eventually, in some fashion, we're going to need to use. And maybe what we do is we use platelets and heparin, low molecular weight heparin early, and then as the disease progresses, add these other treatments. Only time will tell.
Well, I like very much your comment, and I'd like to make one conclusion that I normally recommend for my residents, my colleagues, that they treat these patients.
Yes.
I recommend, in case of doubt, use the low molecular weight heparin.
Right.
It's better because the incidence of complication is low.
Very low.
Especially if you use low dosage of low molecular weight heparin, and you can have very good results. It's better to use than do not use.
I think
this is my recommendation. I'd like to know if you agree with this or you
very
disagree.
important. Very important to emphasize. Nobody dies from a prophylactic dose of low molecular weight heparin. Nobody gets a serious or semi-fatal bleed from low molecular weight heparin, let alone in this illness, which is loaded with thrombosis. The whole thing about this disease is surrounding thrombosis, lots of thrombosis. So before I leave, if you have a few minutes, I'd like to share a couple more slides, because these slides are what I prepared. After I get off of this conference today, I'm going to do another lecture for the patient.
Good.
And I'd like to share those slides with you. And then I would like to, I've decided I'd like to get some payment for this webinar.
Okay.
Are you ready?
Yeah,
Yes.
we're ready. We
Sure.
will just,
Right.
we will
The
need
payment,
it over-
the payment should be, I'm going to send you this patient-friendly set of slides, and I would like you, I will send the video, and I'd like you to put subtitles in Spanish for me,
Okay, we will set up that.
so I can share it with all my Spanish people around the world. So
Fine.
that's my price.
Okay, fine, excellent, thank you.
All right, let me show you can I show you the slides?
Yeah,
Do you have time?
yeah, sure.
What happened to my computer here? I have to. All right, here we go. Okay, this is entitled, Everyone Needs to Know Their Caprini Score. Fatal pulmonary emboli are the #1 preventable cause of death in hospitalized and surgical patients. Appropriate anticoagulant prophylaxis can prevent most deaths. Risk scoring identifies who is at risk for these emboli and guides the physician choices for preventive measures. Providing prophylaxis for the entire period of risk is the key to preventing these deaths. Everyone has unique risk factors that make one prone to developing a pulmonary embolus. You might say we all have our baggage: obesity, cardiac or pulmonary disease, cancer, family history of blood clots or stroke, diabetes, hormonal therapy, etc. And of course, coronavirus. A risk score can be calculated based on these risk factors that is predictive of a thrombotic event if surgery, injury, or illness occurs. Knowing one's baseline score is an important part of their baseline medical record. Informing healthcare providers with this personal information is critical, especially if one contracts the coronavirus, experiences a disabling stroke, or requires emergency surgery. Now, we've already been through the Caprini score, so I will not repeat that. But when I dictate all of this, then you can put the subtitles in, and you know about the patient-friendly score. So capturing all 40 elements in the score is a time-consuming process. So we need to use the patient-friendly version. And individuals should huddle with their loved ones to complete their score thoroughly, evaluating the risk factors in the score. And I want you patients to do that today. A family physician should then be consulted to verify and calculate a final baseline score. The results should be kept in a safe place and available to other family members should the need arise. The most important is having loved ones aware of the baseline score should the patient be in coma from trauma, stroke, or even the virus. The baseline score can be presented by the patient or the family members to the healthcare provider when injury requires casting or immobilization, when somebody develops the virus, diagnosed either because of symptoms or exposure, or is admitted to the hospital for serious illness or surgery. Rescoring the patient needs to then occur during hospitalization. Remember, some of you outpatients will need anticoagulant protection based on the revised score if you have the virus. Now I'd like to address immobility because it's a very special and poorly understood problem. Immobility is a well-known risk factor for thrombosis. But first of all, it's not the only risk factor. Patients that are at bed rest and then start to ambulate, they can't stop their anticoagulant prophylaxis just because they're ambulating, because normally they will have other risk factors. And ambulation does not correct obesity, heart disease, history of thrombosis. It just corrects bed rest. Now, people need to be able to walk 30 feet. I believe that's 10 meters at one time. And in the Medinox study, which was done in 1999, it was a worldwide study involving giving patients, medical patients, either low molecular weight heparin or not, to see the value of low molecular weight heparin. And it turned out that low molecular weight heparin was very valuable. Then a subset analysis was done in patients who didn't have prophylaxis, whether or not they could walk 30 feet. And the incidence of venous thromboembolism was decreased from almost 20% to 10%, or a 50% relative risk reduction if they could walk 30 feet. So patients who are using a cane or walker for stability are not considered as having restricted mobility. So it's still, if they can walk 30 feet, it still counts, as long as they're using both legs. Sitting up in the chair or walking a short distance to the bathroom does not qualify as ambulation. It's still bed rest. And most importantly, if a person has a cast on the leg or a boot that inhibits normal calf muscle action, and especially if it's non-weight bearing, that patient's immobile, regardless of how far they walk with the other leg. Would also like to point out that when we complete the Caprini score now, we have decided if you're positive for the virus without symptoms, the score is 2. If you're positive with symptoms, the score is 3. And if you're positive with a D-dimer positive, it's 5. And the healthcare team should update the score during hospitalization and at discharge. And the score should be revised during hospital stay, reflecting reoperation, infection, central lines, cancer. And the updated score will often result in a change of thrombosis prophylaxis, including the post-discharge anticoagulant prophylaxis. This score is a dynamic instrument. It's not a one-time thing. The American Venous Forum recommends that all patients admitted with the coronavirus should receive low molecular weight heparin. And if the score is over 8, or they have BMI of over 35, heart failure, positive D-dimer, past history or family history of thrombosis, they need to have double the dose. Patients need to rescore to discharge, and again, using extended chemical prophylaxis for scores of over 8, and those other factors which we previously mentioned, including elevated D-dimer, BMI of over 35, limited ambulation, history or past history of venous thrombosis, heart failure, as an example. Here is the slide from 2008, folks. It's 12 years old. And look what we see here, that my brilliant Spanish fellow, Juan Arcelas, and Manuel Monreal, and those beautiful people that run the Riete registry. This is from the Riete registry. And this shows that 77% of people get their clot once they go home from the hospital, and 55% after anticoagulation is stopped. Where were the guidelines looking at these data? Now, and we know that high Caprini scores receive extended prophylaxis. What about the coronavirus? This makes the interpretation of these data even more critical in the era of COVID-19. So, in conclusion, perform thrombosis risk assessment using the patient-friendly version assisted by your loved ones. Share the results with your family doctor to verify your final baseline score. Save the results as part of your medical record that other family members can access. Remember, if you develop COVID-19 as an outpatient, anticoagulant prophylaxis may be appropriate. Ask your doctor about continuing anticoagulant prophylaxis when you are discharged. And remember, and your doctors and healthcare providers have all got to remember never to kill a friend, never to treat a stranger. What that means is that a thorough history and physical must be performed, and that has to start with you, the patient. And then you have to present that to your doctor, and then your doctor has to fill out the form. And then if we know all of that about the patient, you no longer are a stranger to your doctor. And of course, the doctor should never treat a stranger, but should never kill a friend. And finally, did your doctor ask all of the questions to make you his or her friend? So with that, I'd like to thank you all for your attention. Stay safe and have a wonderful day. Please visit our website at venusdisease.com or my YouTube site at Venus Resource Center. Thank you so much.
Okay, thank you very much, Professor Caprini. It was really a crazy way to learn everything. You teach us a lot. Thanks with my deep of my heart. I will just to have a final remark from the Vice Dean of our university hospital to finish the talk, and after this, I will have you having a final thought. Profesor Machain.
Sí, excelente la conferencia del profesor Caprini en representación de la Universidad Nacional de Asunción. Nuestro más sincero agradecimiento, ya que esta Universidad Nacional de Asunción, la Facultad de Ciencias Médicas, tiene como norte la docencia, la investigación y la extensión universitaria. Y esta conferencia está ayudando a cumplir todos esos fines que habíamos nombrado. Congratulaciones, profesor Caprini, muchas gracias, y esto es dinámico, así que en cualquier momento estamos nuevamente.
Okay, thanks, Professor Caprini. Professor Machain said that the University of Asunción, Paraguay, Facultad de Ciencias Médicas is very happy to have you as giving us the talk, and we will just share more presentation in the near future. We will try to send you just a certificate of appreciation from the university to keep you in your records, having you one more university in Paraguay to have for your future CV with us. Thank you very much for everything. Muchas gracias por la presencia de todos ustedes, señores. Les recuerdo que en la segunda etapa vamos a tener algo mucho más pesado, que va a ser con unos jóvenes de Nueva York. El grupo nos va a hablar de su experiencia. Vamos a tener un neumólogo, profesor San Martín, que es jefe del Hospital Saint Vincent, que es el doctorado. Vamos a tener un cirujano vascular y vamos a tener 3 especialistas hablándonos del mismo problema que estamos teniendo el próximo sábado. Professor Caprini, your final remarks and your closing for this excellent talk. And I just would like to remember that the YouTube is ready to just go through the presentation and save it or release it or share it whenever you want it. is in the database of our lab. I will just send the link for the future, Professor Caprini.
Thank you very much indeed. I can't tell you what an honor it was to be able to visit with all of you distinguished professors and share information about this terrible disease. Later today, I will finish the patient-friendly lecture and send it down to you so that you can make your payment by putting in the Spanish subtitles.
We will do the stuff that you want.
Yes, thank you.
Our technician, we will be doing without big trouble. I will send it back to you. Thank you very much for your help.
Thank you.
Have a great day, and we will see you in the next presentation or in the near future for an update, maybe in 3 to 6 months after we will release of that stuff that is a big trouble, the COVID disease for all over the world. Muchas gracias, muchachos. Gracias por la presencia, estimados profesores. Gracias, profesor Ángelo Scuderi. Gracias, profesor Bataglia, profesor San Martín y a todos los que estuvieron acá presentes. Estamos realmente trabajando todos juntos. La Universidad Nacional de Asunción está muy contenta, la Facultad de Medicina, porque una de nuestras misiones es la enseñanza. Este video va a estar grabado y va a tener la posibilidad de ser pasado y compartido con los residentes y en las residencias para tener una idea de lo que está pasando. Muchas gracias a todos y nos vemos todos juntos el próximo sábado. Muchas gracias a Kinfa, que es el que nos dio este espacio y nos dio este grupo el lugar en el virtual para poder seguir desarrollándonos y desarrollar la docencia. Muchas gracias a todos y me despido con un agradecimiento del corazón. Thanks, Professor Caprini. Thank you very much for everything. And we will see you together in the near future. Have a great day, everybody else. Have a safe weekend, and I hope you enjoy the weekend and everybody else that will happen for the near future. Thanks for everything. Muchas gracias por todo. Bye bye.
So thank you. I want you to know that I'm always available for my friends in Paraguay at any time. Send me messages. I'm always happy to come back and discuss with you. It's a great pleasure. Have a wonderful day.
I will share your email to all those guys to send you some kind of recommendation and ask you if they are in trouble. Thank you very much. Muchas gracias, muchachos. Le voy a pasar el email del profesor y está en el grupo, así que por favor, siéntanse libres de comentarle cualquier problema en algún momento. Muchas gracias, muchachos. Suerte y que tengan un buen día.
Thank you.
Thank you. Bye-bye.